Hello and welcome to The Checkup. I'm Nona Tepper, Modern Healthcare's insurance reporter. I'm joined today by JAMA Editor-in-Chief, Dr. Kirsten Bibbins-Domingo, to talk about her first 90 days at the helm of the scientific journal and what JAMA's future looks like. Dr. Bibbins-Domingo, welcome.
Thank you so much for having me.
I'm excited you're here. As I mentioned, you're in your first 90 days in the post. Can we get a little bit of background on you and what about your career and personal life attracted you to the position of editor-in-chief?
Sure. So I'm a general internist, and I've been a professor at the University of California, San Francisco in the Department of Medicine and in the Department of Epidemiology and Biostatistics. And I've been doing that most of my professional life. I have long sought to be published in JAMA, but really hadn't had any experience working on the other side as an editor. But I have come over the last many years, and probably accelerated during the pandemic, to really appreciate the importance of how we communicate about our science and how doing that well can really have an influence on how we practice medicine, how we design health policy, how we influence public health. And so when the opportunity came up that this position was open, I applied sort of on a whim, and then realized just what an extraordinary platform is. It turns out I'm the editor-in-chief not only of JAMA, but of 13 journals across the JAMA network that publish quite a bit of science, publish the context, the editorials, the opinions that shape science and medicine. And really, it's an extraordinary time to think about communication, and I feel really honored to have this role.
Wonderful. You replace Howard Baukner, who stepped down after JAMA aired a podcast and posted a tweet questioning whether structural racism exists in medicine. How do you plan to address what many say is structural racism embedded within these scientific journals?
Well, I would say that every institution in our society, and certainly all of our institutions in science and medicine, have really come to start to reckon with the fact of these deeply ingrained biases that really affect the conduct of science, affect the care we provide to our patients, affect a lot of things. And so many institutions are in the process of trying to understand how those deeply ingrained and deeply embedded biases that are in place have shaped what decisions are being made, and by facing that, understanding how we can start to undo those. I would say that the issues that JAMA faced are not specific to JAMA. I would say these are true across scientific publishing. It's things we struggle with in academic institutions, and certainly in the conduct of healthcare. And I think the opportunity to think with real deliberation in how we structure our editorial boards, who works for us, who are part of our reviewers, who we ask for opinion pieces on, who sits on our editorial boards. I think it's really critical, because who's in the room matters, who's making a decision matters. And really what we want to be doing is making sure that we always attract the best science, always have the right voices that really reflect the breadth of views on important issues in science and medicine. And that's the opportunity that we have at JAMA to think about this in the way that I hope all of our institutions in science and medicine are doing.
It is certainly a tremendous opportunity. Are there any editorials or any changes you've made that highlight new or different voices in the first 90 days that you're exceptionally proud of?
Well, there's several things that we're proud of. We host a big peer review congress every 4 years, I'm sorry. We hosted it here in Chicago, and bringing together scientific journals from around the world. One of the most exciting talks there was how we actually collect data about the demographics of who makes up editorial boards, peer reviewers, so that we can assure over time that we're really reaching our goals to be as inclusive and equitable an environment in scientific publishing. And we look forward to continuing to work on that. Across JAMA and the JAMA network, we have hired deputy editors in all of our journals who are deputy editors working as editors do, but who have specific focus and expertise in areas of equity, diversity, and inclusion. And it's great to see them coming together to think about how to continue to shape our journal. We've always done quite a bit of publishing in this area, and you'll see that continue. And then I think when we've taken on major theme issues, an example, at the end of September, we published a major theme issue on gun violence in the US. I think we are thinking about the issues of gun violence from a variety of different perspectives, and you'll start to see us continue to do more of that as well.
That's fascinating. Thank you for sharing that with me. Your new position also comes as the COVID-19 pandemic highlighted deep inequities within our healthcare system. How can journals work to build trust with their audience? And should the JAMA network serve as a counter to misinformation among patients and consumers?
This is an issue that's really very near and dear to my heart. We're proud of what we publish in JAMA, and across the network, we do a lot to publish explainer videos to try to reach lay audiences. But it's very distressing that at this time, the strains of other sources of misinformation and then more targeted sources of deliberate disinformation really is challenging. And so as just a layperson, or even you or I, we're constantly being bombarded with information from places that we trust, but also from a lot of other places, and sorting it through to understand, well, how should I, as a patient, how should I, as a clinician, make a decision, especially because there's so many sources of information, and then a few strains of very deliberate focuses of disinformation. It's such a critical time for all of us who are in the communication business to figure out how to do this in the best way possible. I think you're highlighting the areas in the pandemic where these issues that have always been there became magnified, oftentimes more highly polarized. I think our job as a journal is to make sure that we have a high integrity in our process for deciding what science to publish, but then to also think about all of the ways we can disseminate our findings in a way that it can really influence as broad an audience as possible. And the one thing I've learned over the years in being in various roles where communication was at its core is that you're never just communicating to the group that you think is your core audience. You're always communicating to a much broader audience, and keeping that in mind is really critical, I think. And you will see us continuing to do this, which communicating to a broad audience, including patients, a lay audience, policymakers, the general public. But you'll see us doing it in a way that recognizes that there are other, oftentimes competing sources and sometimes deliberate sources of disinformation. And so amplifying our voice probably a little bit louder than we have been in the past to make sure that people really are aware of what the science tells us is the best evidence at this time.
That's exciting. I'm looking forward to more amplification from you guys. When you mention, making sure you're publishing scientific research to the highest integrity, I get so many pitches daily about health equity initiatives from healthcare systems, insurers, patient advocacy groups. I'm wondering, how do you measure the impact of a health equity initiative, and how do you separate all of these initiatives?
Yeah, it's such a great question. So, for me as somebody so my own work, before coming to JAMA had been focused on health equity in cardiovascular disease primarily, and also in COVID-19. And there is a part of me that is thrilled that you start to see health systems now embracing this, academic institutions embracing this, and as you suggest, many health equity focused initiatives. So that part is thrilling. But as you suggest, the question is, well, how do we know that these work? Do they really have the goals? How do I evaluate one versus the other? And I do think that's where me and my primary way of being in the world is as a scientist. And so I'm deeply rooted in the principles of health equity, but I, like you, want to know, well, how do I know that this works? And how would I know? And how would a hospital know if we have this initiative that we have goals? I think the great thing now is that we do have places that have been doing this for a while, who have thought about the metrics, who have thought about the measurements over time, who have thought and recognized that this work has to be done in partnerships with the communities and patients that are most affected in order to have the greatest impact. And I do think we're at a time when we don't just want to adopt the latest health equity initiative. We want to learn from groups and organizations that have been doing this for a while. We want to work in partnership with others in the communities that have been most affected by the issues related to inequities in health. And then we want to be deliberate in our measurement to understand, like, what is working, and then how can we tweak things and design things better. As a journal that publishes science and that publishes rigorous science and is deeply rooted in health equity, we do want to be publishing those so that the broader healthcare community can understand what initiatives do work, because these issues are urgent, but they do need to be done well, and learning from how others are doing them well, I think, is really important as well.
Certainly. Are there any health equity initiatives you think should serve as a model for other organizations, or any health equity efforts that have fallen short that you think we could learn from?
Yeah, I don't know that I could call any specifics out at this time. I will call out what I do think are principles that I've seen over time in initiatives that have worked. I think the initiatives that really are not just designing interventions that I think would work, but rather designing interventions that really involve the people who are most affected, I think is really a principle that underlies those interventions that have been most effective. I think what makes health equity work can be challenging is that it is, by its nature, it needs to be done in partnership. The issues and the biases that lead to inequities are really multifactorial, and undoing them in a deliberate ways requires getting people at the table who really understand how we get to the point of having these very big gaps in health, and then thinking in ways that is deeply rooted in expertise and experience, to saying, well, no, this is the way we have to try to undo that. And that takes a little bit more work. It's harder to do, but I think that's the hallmark. I think another key hallmark is the measurement issues. We have to be able to understand and how to do this over time. The great thing in healthcare, as you know, is that our issues, we used to not understand how to engage in quality improvement method interventions in healthcare, but we have over time recognized that when we bring the right people to the table, when we're clear what we measure and what our goals are, when we do process of continual improvements to learn from what's not working and then to try to do that better, and to all the time monitor and measure to make sure we're reaching our goals. I think those types of principles can be applied to the same issues related to health equity. But I do think that they will take sustained effort, they will take true partnerships, and they will take real measurement and just to make sure that we're making progress over time. But I'm optimistic that we can do this. In healthcare, the issues of equity are not separate issues. They're really embedded in the idea of, well, how do we do the best for all the patients who come into our hospital when they come in there or come into all of our clinical settings? And that is a core value that healthcare should embrace. And so I don't think the equity issues are separate. They're just part and parcel of what we should be trying to do in healthcare organizations.
I love health equity as a quality improvement activity. I think that makes a lot of sense. In your first editorial for the JAMA network, you mentioned we needed to guard against the threats of insularity and parochialism. I'm wondering what you meant by that and how do you intend to do that?
Yeah, I think there's a tendency for us always to think that, well, we recognize this as an issue, so therefore we know the answer to the question, and we each have our own expertise, we have our own experience, um, but all of us have to guard against thinking that that experience represents the entire universe of patient experience or of a scientific approach to a problem or the way one designs a healthcare intervention. I'm a firm believer that we need more voices in the room, particularly at to address the most challenging issues that face medicine, that face science, that face health in general. We need to really understand from people who have different experiences from our own in order to think about either the design of the best intervention or an evaluation when we talk about evaluating a scientific article. And so we have to approach everything with a little bit of humility. And when we're designing systems or we're designing big journals like we're in the process of doing, we want to make sure that we have many voices at the table to really understand how to do this the best. I have to say that it's a general principle in science that really that good ideas come from many corners, and I think for those of us who are in the business of trying to catch the best science and to amplify it in a way that it can really affect the practice of medicine, we want to make sure that we're always open to the breadth of where good ideas are going to come from.
Thank you for your time. I've really enjoyed this conversation. This is Dr. Kirsten Bibbins-Domingo. Thank you so much.
Thanks for having me.